want to thank the organizers for this opportunity to present. Again, my name is Dr. Alexey Alishin. I work at Natera. I'm the General Manager for Oncology. And today I'll discuss with this group kind of some of the recent data that's emerging in the space of circulating tumor DNA. As clinicians, we frequently really struggle with understanding which patients are cured after, for example, surgery or definitive treatment for early stage cancer. There's been a lot of tools that have been developed over the last, few decades, better imaging, better risk assessment using things like cancer staging. And there also have been, different serum protein biomarkers like CEA that can be used to really try to figure out, for example, whose cancer is cured and whose cancer may be coming back. But none of these tools are perfect. And whenever somebody has surgery, we always wonder, is this patient's cancer going to come back, or is this individual cured? And because we never know this with certainty, frequently we have to treat patients all the same by, for example, prescribing toxic chemotherapy in the adjuvant setting or things like radiation therapy. And this is really where the field has started shifting to look at things like circulating tumor DNA, which we'll spend the rest of this session discussing. I think many on this call probably know what circulating tumor DNA is, but just very briefly, all of our cells, cancer cells included, when they die, they shed little pieces of DNA into the circulation. The really great thing is that this DNA is in a balance. It's always being released and always being degraded. And the half-life is really, really short, anywhere from 60 minutes to maybe an hour and a half. So it's a really dynamic biomarker that allows us to know, for example, how much cancer somebody has in their body. And after surgery, kind of with newer tools, we can really be able to now detect this circulating tumor DNA to very, very low levels, which before was not possible. The way we do this at Natera is through a test called Signatera, which is what we call a tumor-informed and personalized approach. Levels of circulating tumor DNA in this adjuvant setting, are sometimes 100 to 1,000 times lower than in patients with advanced or metastatic disease. We're talking about like one molecule in 2 tubes of blood. So the way to be able to detect such low levels of DNA reliably is what we kind of call a tumor-informed approach. So we actually start by doing whole exome sequencing. We look at all of the genes in the patient's tumor and identify all of the clonal mutations that are unique to that patient's cancer. We then design a personalized assay to look for 16 of the most clonal or truncal mutations in that cancer. And once that assay is designed, it can be used sequentially throughout that patient's treatment journey to monitor levels of circulating tumor DNA down to extremely low levels. And this allows us really for the first time to have a dynamic biomarker that can be used throughout the patient's entire treatment journey. So for example, before surgery, patients may receive neoadjuvant treatment to try to shrink the tumor. After surgery, patients may need adjuvant therapy. In the surveillance setting, it's important to know, is somebody's tumor coming back accurately? And in patients who are unfortunate and have their cancer come back, ctDNA can also be used for treatment response monitoring. So this is a really great tool that can really follow a patient throughout their entire treatment journey. And the really exciting thing, I just really love this figure, is that ctDNA is one of the most kind of sensitive and specific biomarkers for identifying who is cured and who is not cured of their cancer. So for example, after surgery, you can't see any cancer on the scan. We call that being NED. But if we find traces of ctDNA using Signatera, the chance of this patient recurring without further additional therapy is close to, if not 100%. So you can see all of these blue lines, they go to 0. There's very few censored check marks, really suggesting that if you have ctDNA, even if the imaging is negative, this patient is really almost destined to recur without additional therapy. On the flip side, patients on the green line who are CTA negative, and especially if they say CTA negative on serial testing, these patients have amazing prognoses. You can see that the majority of these patients do not have their cancer come back. So really, for the first time now, we can stratify patients into 2 groups. Patients who still have tumor in their body, even though you can't see it, we call this molecular residual disease, or patients who are likely cured, And this really now opens up a lot of therapeutic possibilities that are being examined in certain studies that we'll discuss. And kind of to drive this point home, kind of the way I sometimes describe this is that imagine somebody with stage one disease. Usually these are the patients we tell, hey, you are going to have a really good outcome. But if that individual is CTA positive, this patient has a way, way worse prognosis than a stage three patient, for example, that has perforation, obstruction, every single known high-risk feature. But if that patient is CTA negative with a stage three high-risk disease, that individual's risk of recurrence is markedly lower than that stage one patient with ctDNA. So even things like staging are now being redefined. Instead of thinking about TNM staging, more and more we're thinking about TNM-B staging, where the B stands for blood-based MRD status. So just to kind of tie some of these concepts together, I want to actually go through some results in colorectal cancer that were generated from a large study in Japan. The exciting thing is that this study really looked at all of these phases of a patient's treatment that we previously discussed. And the study was called Circulate Japan. And really the schema is laid out here, but the important thing is there's really three arms. The first arm is the screening study called Galaxy. And then patients who are either CTA positive or negative are able to then switch over to either the Vega study or the Altair study, which are randomized de-escalation and escalation studies, respectively. Today, we're really going to focus on the Galaxy study, and this is because some of these results have been presented and published. So in the Galaxy study, the patients were being tested for ctDNA prospectively on these intervals. So you can see before surgery, after surgery, and then serially during the adjuvant therapy, as well as into surveillance. The really exciting thing is that, this study was really large. It was over 6,000 patients. And the initial results that have been presented, included around 2,000 of those patients that were eligible for evaluation. So let's kind of break down some of these results in a few categories. The first one is, just how prognostic is the test after surgery? So looking at what we call the MRD window, which is just a few weeks after surgery, and this is kind of where the critical decisions about if to give somebody treatment or not to give somebody treatment are being made. Signatera positivity, as you can see on the blue line, for both all stages and then some of the clinically relevant kind of high-risk stage 2 and stage 3 patients, you can see that these blue lines really drop down very quickly. And the hazard ratio associated with them is, 11.9 for all stages and over 13 for kind of the clinically meaningful stages where a lot of these adjuvant decisions are being made. So really the way you can think about this is if you're CTA positive after surgery from a single time point, your risk of recurrence is something like 11 to 13 times higher than if you were ctDNA negative. And furthermore, when we look at all known risk factors, right, like, things like how big the tumor is it in the lymph nodes, does it have certain high-risk mutations? A lot of these things that are traditionally used today to assess risk drop out as being insignificant in multivariate analysis. And really the only few things that remain significant are, is somebody CTA positive or not? And then some other molecular features that you can see here. For example, is somebody MSI high or low? So because of this, you can also now ask, well, if somebody is high risk, well, can you actually modify that patient's outcome? And the answer is excitingly yes. So when we look at patients who are CTA positive, we said on average, they do, 10 times worse than if they were CTA negative. But as you can see, if they receive adjuvant therapy, and these are the green line right here, you see if patients do receive adjuvant chemotherapy, their outcomes versus if they don't markedly increase. So basically, instead of almost everyone recurring, we see that, almost 40% of patients are able to be cured if they were in this high-risk CTA positive group. Alternatively, CTA negative patients, regardless of if they get very toxic chemotherapy, seem to do just as well if they're either treated or observed. Right. So this is really kind of exciting data that may help us redefine how we select patients for adjuvant treatment. Furthermore, this is not just something we see in terms of DFS or RFS. This is does somebody's cancer come back or not, but it also translates into overall survival. And I think in the end, this is the most important thing. Can we help patients live longer? And you can see that for CTA positive patients who receive adjuvant therapy versus the ones who don't, these patients have almost a 50% decreased risk of death, while again, patients who are CTA negative seem to live just as long and actually have amazing outcomes, regardless if they receive chemotherapy or are observed. Furthermore, we can also track DNA using Signatera longitudinally. So we can see that patients, for example, who go from being positive to being negative and stay negative, these patients do amazingly well, right? So these are the same patients that on aggregate had, almost 100% risk of recurrence, right? Without treatment, we showed that with treatment on average, 40% of them could be cured. But more importantly, if these patients, if you can see that CTA drop and stay at zero, that patient's moved from that really high risk group to a group that does exceedingly well, right? Look, very few of these patients have recurrence. These patients do almost as well as patients who are CTA negative to begin with. On the flip side, unfortunately, if patients do not clear their ctDNA, if they continue to be CTA positive or go from negative to positive at any time, these patients, unfortunately, all recur, or pretty much all of them recur. And really, this provides opportunities for us to think about maybe escalating therapy or changing the way we treat these patients by being able to assess response in real time. Furthermore, people ask, well, if somebody, for example, clears, how long do we have to keep checking? When is the biggest risk for somebody for their CTA to come back after therapy? And here we can see that most patients, if their CTA were to come back, it happens in the first kind of year to year and a half. And after that, if somebody's negative, they're very likely to stay negative further out in their surveillance journey. Lastly, I think this also translates into overall survival, right? So not just looking at somebody's cancer come back, but really asking the question, do people live longer? And I think for me, this is almost, it's almost amazing to see that patients who start CTA positive, who we know do so poorly, they receive the appropriate therapy and they go from positive to negative and stay negative with Signatera. These patients actually in this study had 100% overall survival. These are patients who were likely not cured by their surgery, but with effective therapy and being able to monitor that therapy's effectiveness, they would be able to be moved into this bucket. Patients who have persistent CTA or their CTA goes down but then comes back, these patients unfortunately do much worse with their risk of unfortunately dying from their disease being anywhere from 25 to 75 times higher than patients who persistently go from positive and stay negative. So, a lot of studies now are really asking the question, well, how can we move patients in these buckets into that green bucket? And, I think it's nice to just kind of wrap this up with a patient story. And this is actually a 69-year-old male. He had what we call stage 2 or T3N0, early stage colon cancer. So you can see the molecular features are pretty typical. This is a microsatellite stable tumor. The KRAS mutation, which is very common, is present with the G12V variant. There were some higher risk clinical features. There was a perineural invasion, but margins were negative. There was adequate lymph nodes sampled. And, frequently this is a tough one. You could possibly treat this patient with adjuvant chemotherapy per current guidelines, or you could observe this individual. And I think this is kind of where tests like Signatera really come into play. So for example, in this individual, they were CTA positive after surgery, right? So even though this patient on the surface looked pretty low risk, this actually placed them in a much higher risk bucket. You can see that with therapy, Zelox, this patient received adjuvant therapy and actually went from positive to negative. And we've said that before, that this is actually a good sign. but only if patients stay negative long term. But this patient's ctDNA did come back, unfortunately. But this allowed the clinician to actually find the recurrence, do a CT scan, find a recurrence in the liver. And by treating that recurrence, we can see that this patient's CT actually dropped and has stayed negative on long-term follow-up. And really, this kind of also brings up the question, well, by using tests like Signatera, if we can pick up recurrence earlier, can we actually give patients a second chance at cure? So, in summary, I think the field is moving quickly, right? This is one study out of hundreds of studies that are happening in this space. We as a company, I think last time I checked, are involved or supporting, over 50 studies in this space alone. So beyond colon cancer, ovarian cancer, breast cancer, bladder cancer, all of these fields, ctDNA is being evaluated. And really the field has started moving past the question of, what does it mean for somebody to be ctDNA positive, to really answering the question, well, how can we use this to modify treatment to really hope to improve patients' long-term outcomes? So with that, thank you everyone for your attention, and I can take questions if any exist.
Thank you so much, Dr. Alishin. This was an amazing presentation. Honestly, I was taking notes and this was very interesting. And for myself, being a radiologist, just having this, the way of stratifying this patient. So basically will allow the further imaging to be more on time and of course more precise. My one question is regarding the last actually 2 slides before they showed that the patient got a relapse in liver lesions. So basically, RFA was enough to just see the circulating DNA go down to basically to the initial levels, actually to zero, to be negative. Is that correct?
Yeah, I think, yeah, in this case, obviously, it worked out very well. But, I think that's kind of where this can be super helpful because let's
Mhm.
say some kind of definitive therapy is done, surgery, RFA, but
Mhm.
then CTA drops, but does not go to zero. So we know that that's still a
Yeah.
very bad sign. So that may allow the oncologist to have a discussion about, for example, is additional chemotherapy necessary? And I think, the interesting thing is colon cancer is one of the few tumor types that can still be cured, if a patient develops kind of oligometastatic or limited metastatic disease.
Yep, exactly. And so basically, the continuation of this question, when do you measure the circulating DNA? So, for example, if the procedure is done, doesn't matter if it's just surgery, ablation, or chemo, when is the proper time for measurement?
Yeah, that's actually a really insightful question. So, we studied this actually quite a bit. And immediately after, especially more advanced surgeries, there can be high background rates of just normal DNA, normal
Mhm.
cell-free DNA that just comes from, our tissues turning over. So the bigger the surgery, the longer this increased background. And the way I think about it is it's a kind of almost a bigger haystack. So
Yeah.
it's harder to find the needle, right? So if you find that needle, CTA is positive, you can trust it, but if it's negative, there could be a higher risk for a false
Mhm.
negative. So for most major surgeries like Whipple's, hemicolectomies, we typically say kind of wait at least 2 weeks, maybe
Mhm.
three.
Mhm.
For minor procedures, usually just a few days or a week is enough. And there is quite a bit of data now published that kind of actually shows you that background going up and then degrading with time.
Mhm. Mhm. Wow, thank you so much. I'll ask our audience if they have any questions from their side, because I can talk regarding this topic because it's very interesting. And I just, again, I want to reiterate the fact that stratifying these patients is crucial.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.